Without further ado, call now the next panel speakers to please turn their videos on. We are going to do now is the presentation of the next panel that is going to start, and it includes two streams. Welcome Frederico Calado, welcome Lars Montelius, Paulo Gonçalves, and Astrid Vicente. Welcome so much. So you are going to be a part of the next panel stream that we are going to start transmitting live. So Frederico Calado, all yours.
Thank you so much, Paulo. Welcome everyone to Stream A. I hope if you're interested in Stream A that you will continue with us. I'm very pleased to be part of this very important event. It's an honor really to be also representing Novartis. I'll quickly introduce myself. I'm the head of innovation and partnerships in our Center of Excellence for Real-World Evidence in Novartis Oncology. I'm Portuguese, as you can probably see from my name, but I've been with the company for 9 years, 7 of which in headquarters here in Basel, Switzerland. I think we have a very interesting session today. Quickly introducing Astrid Vicente, who will be talking about precision healthcare and 1 Million Genomes Initiative, which I know a little bit about, so I'm very interested to learn about her perspective about this as well. Then followed by Lars Montelius, who is, I think, based on the slides that he shared previously with the other speakers, going to give us a very interesting perspective on the ownership of data applied to the scenario of a continuous generation of data, less from the perspective of the treatment, but more from a perspective of prophylactic intervention. So I am very eager to hear his thoughts about that. And then finishing with Paulo Gonçalves from SPAM, who will be challenging us to think about treating the patient as a real customer. And I think he's going to draw on a couple of parallel scenarios with other industries outside of healthcare. So very interesting, all very interesting topics for me. As for me, I'll be using a couple of minutes to describe my thoughts on, actually, I think COVID will be a very interesting driver and an opportunity to solve the #1 hurdle to value-based healthcare. Value-based healthcare for me is a very interesting theoretical construct, but has been having some practical issues in terms of its implementation. But I think COVID will help us with that in solving the problem with the lack of flow of health data. So that's going to be my own presentation. So without further ado, I would like to give the stage to Astrid, who will be speaking about the 1 Million Genomes Initiative.
Thank you so much, Rick. Just a point, we are now more than 1,000 live visualizations on Facebook. This is not to make you nervous, but well done, well done.
Okay, good morning. This is a lot of responsibility now. I first want to thank Hospital do Futuro, and I want to thank Paulo for this invitation. It's really nice to be here and to be part of this endeavor that I was not aware of previously. So Paulo had asked me to talk a little bit about personalized medicine. I call it personalized medicine, which is the term that is actually used by the European Commission and the European Union. So we can go on long debates about precision medicine and personalized medicine, but we'll stick to this at this point. And maybe Paulo, you can share my presentation now. Because we were talking, I see everyone is talking about data, then I'll talk a little bit about an initiative, a European initiative from the member states supported by the European Commission that I think will be very important for healthcare and certainly health research.
I ask you to bear with me for a moment because I'm now experiencing I need a few more seconds. Can you please start sit down and follow up in a minute?
Yes, no problem. So I'll just provide a little bit of context. My first slide is really to provide the context regarding variability of the human population. So we're all different. And actually this session is also about patient adherence to medication, and that has sometimes a lot to do with whether it is actually resulting and providing a solution or not. So we're all different, and frequently what happens is that a particular treatment does not have the effect that it was expected. It may, frequently this happens in cancer, but in many other areas of disease or in many other diseases. And so it may not have an effect, or actually it may cause adverse drug reactions. And this is because the traditional treatment or the traditional approach was to treat the disease and not to treat the patient. Paul, if you want, I can.
Yes, I'm just, are you seeing my screen now?
I see you. I don't see your screen.
Okay, and now?
Oh, yeah.
Oh, sorry.
Perfect.
Apologize for this. Go ahead.
So can I'm not sure if
the next one?
Next one, yes. And so actually, to talk about variability, I'll just quote Sir William Hostler, who said, and it's very pertinent nowadays, that variability is the law of life, and has no two faces are the same, so no two bodies are alike, and no two individuals react alike and behave alike under the abnormal conditions which we know as disease. So if you can skip to the next slide. I don't know if I can do this. I don't know if I have access to, but I imagine not. Okay, so our traditional approach to treatment was to treat the disease and not the patient. But what happened is that in a group of patients, we have a lot of variability as expected. It's very much determined genetically in the context of an environment. So it's not just genetics, it's a lot of other things. But what would happen is that the therapy would be, effective for some of the patients, for the majority in general, because once a drug is released actually into the market, it has been widely tested. But there are always a group of patients for which it does not result, and a group of patients that actually show adverse drug reactions. And what personalized medicine wants to do, or precision medicine wants to do, is actually treat the patients according to their individuality or their genetic background or their environmental factors. So when you, to actually do this, you need to test biomarkers, and that can be DNA, or it can be biochemical markers, or it can be imaging markers. And then you can stratify the patients according to their individual profiles. And you can actually apply the drug therapy that is more adequate to them, so that is personalized to them. And there you can improve much better. You can actually have big improvements in terms of the effects and the outcomes of the patient. So you can move. Oh, okay. Yes, thank you. Sorry about this, it's complicated. Now, for a number of drugs, there are already very good biomarkers. So you can actually stratify the patients according to these biomarkers with a lot of confidence. But for many other drugs, this is not the case yet, and we have a lot of work to do. There's a bottleneck and we need to actually define better biomarkers. And to do that, if you can skip to the next slide, we actually need to do detailed profiling of the health of an individual. And this includes genome sequences, but as I said previously, a lot of health data that might be related to biochemical markers or to imaging or any other, anything that can actually be useful to stratify patients, how they react upon certain conditions, how their prognosis is, how the disease evolution is going. And then you can also use and should also use lifestyle information, because we know things like diet or exercise are very important determinants of health and sometimes of disease, and then environmental exposures. And if you actually profile all of these, and there's examples already that are being gathered regarding the importance of having a very good individual profiling, you can actually improve health outcomes by using personalized medicine. Now, one of the things that is really important for this is that you have your good markers, and your good markers can only be actually properly identified if you have a dimension of population that allows you to reach conclusions. So in fact, if you want to stratify patients according to biomarkers, you really need a lot of data. So you're collecting a lot of data individually for each of the individuals, and this may actually help you both define the better course of treatment or predict or estimate the risk for a certain disease. And this is very important mainly for very complex, very common disorders like cardiovascular disease or neuropsychiatric diseases or autoimmune disease. But then when you put it all together from a lot of individuals, you can actually collect a lot of data that will help you in identifying the correct biomarkers and looking at what each of the biomarkers is actually contributing for the risk of disease, for instance. So this is where this type of data sharing initiatives are so important. And Paulo, if you can get to the next slide, please. So the 1 Million Genomes Initiative is one of these initiatives that I wanted to mention to you, partly because I'm, very much involved in this, and I think it's really, really important. So in April 2018, a number of member states got together and signed a declaration that committed with a commitment to actually deliver cross-border access to genomic databases and making at least 1 million genomes accessible in the European Union together with health data by 2022. So this is a very ambitious goal. It's a very short time frame to do this, but I think we'll be able to do that. It started with a declaration signed by 13 countries. Portugal was one of the first countries to sign, and it's now signed by 22 signatory countries. You can see the map in green are all the signatory countries, and 7 countries with observer status that we really hope will join us in the future. So what we want to do is 2 things. So first, link access to existing databases in each of the countries so that actually the data can be shared. And then with all of that data from all of the countries regarding health and genomic information for their citizens, which may be citizens with a particular disease or just the general population, you can have a proper scale that will allow you to do research and have a clinical impact, because you will have the power to actually, the statistical power to actually reach conclusions that will be useful for clinical care. So you can skip the next slide. Okay, so what I wanted also to mention, and I don't want to extend myself too much, but is that so there's a lot of challenges in setting up a project like this. Part of the challenges are related to the infrastructure. Obviously, data sharing is not easy. Setting up an infrastructure for data sharing is not an easy endeavor. Genomic data have particular aspects, make it quite more challenging. There's an issue of quality of data and homogeneity of data, because we also want to have health data, and traditionally it is not very well organized and not very homogeneous. It's even nowadays, a lot of it is already in databases, but some of it's not, and it depends on the impression of medical doctors, which is very valuable, but it's difficult to actually have something that is standardized in that way. Also knowing what clinical data or what lifestyle data should be included in such a database requires some important decisions, so that we don't regret that, so that we design this properly and we don't regret not having included some factors and some information later. And then there are the healthy issues, so the ethical and legal and society issues, all related with data sharing. And of course, now we have the GDPR, and also that has to be observed. And of course, every national legislation. So this is a very complex process. But from the outset, it was very clear that there is a reluctance from each of the countries to actually put out there the health data from their citizens and the genomic data from the health citizens to be processed and management at a central location. So what we're planning to do is use a federated model that is really somewhat inspired on the cross-border e-health sharing service that is has been in developed for a long time. And how this should work is shown on this diagram here. Each of the countries manages and processes its own data. So if you have a research or healthcare question, you can actually have a query to a hub. And what the hub has is not the data itself, but it's a data catalog. So it knows what each of the country has available to be shared. And then if the question is pertinent and it observes the GDPR and all the legal issues and the ethical issues, then each of the country can provide that data for that limited amount of data to the catalog, and that can be conveyed to whoever asked the question, a research or a healthcare provider. So this can be, of course, very important for research, but also for healthcare. Imagine you are a medical doctor, you have a patient, you cannot diagnose this particular disease. This is very common for rare diseases, for instance. It's difficult to diagnose, and they're rare. And so by definition, it's difficult to find other individuals that have the same disease and have the same phenotype and have the same genetic causes. So then he can share the phenotype, ask a question to the hub and say, is there anyone out there that has a patient with the same phenotype that has a genetic cause that has been identified, so that I can actually establish the course of treatment or whatever for my patient. This also happens to cancer. So we have actually 3 use cases, which are rare diseases, cancer, and then more complex issue of the common multifactorial disorders like cardiovascular or psychiatric disorders.
Sorry to interrupt, but we have
these are cases now. But we're now thinking of COVID-19 as everyone else is, and we're thinking how actually this model can be very helpful to to do research and look into the host susceptibility to infection. So we all know for this disease, the symptomatology is very varied. The outcome is very variable as well. So we would like to know what are the host characteristics and genomic characteristics that may actually have an impact on the outcome of the infection. So this is another use case that might be very interesting and relevant for today.
Thank you very much.
What I had to share at this point, but I'll be happy to answer any questions.
And thank you very much, Astrid. I've been looking at the chat to see if there's any burning questions. We will continue to ask participants to share those. But if I've just seen that there's no burning questions here on this one, so we'll come back to this topic once we open up also for Q&A. So without further ado, I would ask kindly Lars to share with us his vision on how technology is going to enable for us to shift from a treatment to a preventive mode with health data that is going to be generated in a continuous basis from the patient. Lars,
thank you very much. First of all, let me thank you, the organizers, for inviting me. So when I try to share my screen, the host has disabled my possibility to share. So maybe, Paulo, you could share the...
Can you try again now, Lars?
Yeah, I'm fine. Can you share?
No, I have re-enabled. You can share now.
Okay, you have enabled me. Okay. Yeah, okay, yes, good. Let me see. Where do I have it?
I just want to remind you that if you could possibly end by 11, that will be perfect, so that we can then take you for the question and A's and bring the other panelists in.
Can you see my screen now?
Sure.
Can you see it?
Yes.
Okay, very good. So thank you again. So just to very shortly, as you see, my name is Lars Montelius. I'm not from Portugal, I'm a Swede. I'm working in Portugal now since 6 years. I'm the director for INL, which is an intergovernmental research laboratory situated in Braga, Portugal. And during these 6 years, we have grown from about 60 people to 450 people from 42 different countries. And we're really working on nanotechnology and advanced materials in many different areas. So I would just like to share with you some of these things today. So the introduction, principal introduction that was given by Esther, I think is kind of summarized maybe in this kind of diagram in a way. You have your body, of course, which you can think like a machine, right? So it's a machine with different things happening, different processes, different interactions, very complicated. And then you have the lifestyles, of course. Before that, maybe the inputs is the food we eat, of course, the air we breathe, the light we're exposed to, the sleep we are doing, etc. Lifestyles, the way we are exercising or not exercising, if we are smoking or not smoking, etc. And then we are getting symptoms, and now we are doing the, let's call it the treatments, which is kind of focusing on the precision medicine or the personalized medicine, using, let's call it data support or big data analytics in order to be able to take more better conclusions from a large variety of people, because we're all different, right? And what people are doing nowadays is to look much more on biomarkers, not only in the healthcare sector, but also by themselves, by different things, very kind of high order cohesive biomarkers like sleep patterns, pulse rhythm, etc., etc., which are not really very good markers or identification things. And what is happening now, if you think about society, and you think about what has happened in society, is of course that electronics, if you call it like that, has been an exponential development. So computers that costed $100,000 is what we have in our Apple Watches of today. So the cost for electronics has become ridiculously low, which means that we can make specific sensors that principally can sense all the different things. And this is happening now in industry, and this is usually called Industry 4.0, where you put sensors in all kinds of machines, even in the individual screws, that gives predictive information if you need to go and tighten the screw. You don't need people to go around and check things. It's the equipment, the machines, the society that gives you information that you need to do something. And this kind of development is now, of course, if you think maybe 5-10 years from now, you will have the possibility to have sensors in your body that will sense each individual, let's call it motor or machine or process in your body, and gives out data. And if you think about that concept, what we will have is like biodata, we've had data analytics, and we can start to do what I would say preventive maintenance. And we will start to think about that the data coming out from our bodies, we as individual people cannot interpret them, of course. So we need data analytics, we need the help of everyone in a holistic way to interpret them. But then we can start to see differences. If you change your lifestyle, if you stop smoking, you start exercising, you will see the effect on different individual machines in your body, different individual processes in your body. And this opens the perspective for something that I think is maybe one of the most interesting discussion from a, let's call it philosophical point of view, is who will own the data being generated by each individual person, and who will then own the analytics that goes back to guide this person to do different things. And this will totally change, I would say, the paradigm of healthcare and doing much more keeping people healthy instead of treating symptoms. And if you keep people healthy, you may in the future, maybe 5 years, it will not take long. I mean, it's very short, it's exponential, it goes extremely fast. You will be able to reduce the, let's call it the traditional treatment of diseases, and instead put much more emphasis on how can we actually nudge people to behave much more better and give the power to the people to take the decisions. So the data, maybe we need to come to some kind of what is sometimes called the stakeholders capitalism. It's not about the shareholders capitalism, it's about the stakeholders who will exploit the data and who will own the data, which puts effort into a new commons. I mean, a new commons of sharing data, new commons of sharing benefits. And I think I will stop by that now due to the time. So thank you, and I stop my screen, right?
Thank you very much, Lars. I think we have a minute to address a question that came on the chat.
Frederick, do address the questions in the Q&A, if you please. And if you don't just hear the plenary presentations, I think we have still one from Paulo, and then you can host the Q&A in the breakout. Is that okay, Frederick?
Very well. We can do that. Paulo, please. Then the floor is yours.
Sure. Should I upload or share the screen, or you want to do it, Paulo?
Share the screen, Paulo. You can share the screen if you want.
I cannot.
You cannot?
It was my error. Now you can.
Now you can.
Excellent. So not again.
Yes, you can now. No? Well, no, sorry. I have enabled here, but maybe some issues on the screens. Do you want?
I have the presentation uploaded. So if you wanna,
I'll do it. I'll download it here. Just give me 1 minute here.
So while we wait for that, let me start. And the first slide is to thank the organization for this event and the change from the beginning. We had a different kind of congress to prepare, but now with very genius people, they have came up with this fantastic way of sharing the information again. And I'm honored to be part of such a group of specialists. I have so little background in healthcare. My background is in technology, and in particular data privacy, GDPR, as a lot of people mentioned. And I'm here with the perspective of the users of the NHS. So the NHS users need to have more clarity on how to navigate, and we all need to have better answers from the systems. So we have the presentation. So the conference aims to stress how critical data is to improve and to improve the results in health. From the streams, the 4 streams created, we can find some common background. So, and the common ground, sorry. And the customer data is some of that from the previous speakers. We heard about that so much. So the more and better data, the more improvement on the results we get. So our streams remain focusing on having data to direct the attention to each patient as unique. So then the next slide, please. Can you imagine a bank without the customer at the center, the customer at the heart? It's impossible to think these days that could happen. A bank would not survive. And if you look at the media industry or the telecom industry or any other industry besides this one, the health care industry, not knowing their customers, not knowing who is watching the videos, who is using their mobile phones, or whatever, who is buying their products and how they are using their products, it's impossible to think about that. Think about the government. Let's go to the government. And if we go to the government, can you imagine a government not having a consolidation of the taxpayer in a single view? Those countries that still do not have that face really, really strong problems. So we need to have in Europe, at least we have that. So now, does it happen in healthcare systems? And if we talk about private groups, most probably yes. We find that they already focus in a patient as the client and centralize it. But the national public healthcare, unfortunately not. And I'm not really talking about any country in particular. I'm not talking about Portugal or any other country. I'm talking in general. We all would like to have it, but we don't. We struggle to get there. So consolidation and integration of the information is very hard to do because we still have legacy systems and we struggle to remove them or to use them. Some countries are now, and Astrid mentioned it, are now federating data sets and using artificial intelligence and HL7 standard and others and the metadata to support it. Can you imagine legacy systems and metadata working together? I'm really worried about that. Are you sure that mixing AI with legacy? Please, can you move now? Legacy with AI mixed together is really confusing. So the questions we are raising here in Portugal is: do we have the customer at the center in healthcare? Should we continue to maintain these legacies? Should we federate AI and HL7 and the legacy systems? Why not starting from restructuring the infrastructure, the basis? Center the data in the patient and treat the patient as a customer, not as a patient, but as a citizen and as a customer. Please, next slide, please. So we came up with this, and when it says Portuguese society, it means a very large group of societies, patient societies and health societies in Portugal. We're talking about a lot of people, not more than 100. So we are trying to build a new proposal for a national registry to answer to customer-centric solution, GDPR compliant from the basics, scientific research to be able for the researcher to be able to do scientific research and to analyze from different angles, and to be a sustainable solution. These were the first four questions that we studied to address to build this. And I will be very quickly with this, but it also, of course, it has a lot of information behind. Paulo, please. Next slide. Yes. So customer-centric means the data belongs to the user, not to the hospital, to the health systems. So if the information belongs to the user, we need to build the user infrastructure or the user system in the middle, and then all the services around, all the clinical data and the social data around with blocks of information. And then after that, and at the same time, sorry, next slide, please.
Paulo, we have to finish in 1 minute, just to let you know.
I'll finish in less than that. So all the information must be GDPR compliant. So we need to have the patient to consent or the proper rights for the user to address. Next slide, please. This dividing in two different blocks of information, one which we call the daily basis for the users and the professionals to use it, and on the other side we have a massive knowledge data lake that will be able to give the scientific research to the ground to work. And then the next slide, please. And of course, we need to look at the sustainability. For one side, the per transaction for the daily basis, and the other one for contract-based when we are talking about the scientific. Next slide, please, and thank you all. So to have the tailored therapies and patient adherence, we need good data. To have good data, we need to rebuild, not mixing and adding complexity. With good data, we will have the grounds to add real-world data and real-world evidence, like Lars was saying, and add the best technology, including AI and HL7 and so on, and anonymize and safely research. Next slide. Thank you.
Okay, I think, Federico, you have also something to present in the stream, or are you ready to go to the breakout to host the discussions?
I think we can go to the breakout. I think I would like to give time for people to discuss if we have time. I mean, my own presentation actually links with a lot of these topics, so we can try to do it more informally during the breakout.
You can remove my.
I also would like to thank you so much for this interesting panel, and just remind you that if you agree, all these presentations will be in the virtual space of the Health Data Forum, so that people would be available. We also plan to do a little bit of follow-up short video interviews with all of you and have this important content that was shared here today to not be forgotten and to be constantly reminded until the live presential summit that we want to host next September. So I think we are now going to do a split on the breakouts, as you will be kindly invited, all of you, to go onto the breakout for the Q&A that Federico, I ask you to be so kind to moderate. So we are already sacrificing the bio break that we are supposed to have in order to complete the schedule at 11:30 and starting the Innovation Village with Dr. Rui Ivo from the IFARMED is going to do a keynote on 11:30 in the Portuguese time, 10:30 Portuguese time, 11:30 CEST. So I think that without Federico, you can still round up any comments and final conclusions while we wait for the participants of the breakout to joining us. Federico?
Sure, absolutely. So I was very happy to hear the three presentations. Like I said, my own presentation, we can just skip it, but I will try to tie it back with some of the things that were said today. So basically, the point I wanted to make today is that as a proponent of value-based healthcare, I think healthcare systems and the stakeholders in general are trying to achieve a couple of things. To improve the quality of care, and we heard Astrid's presentation on how we can actually use more targeted approaches to actually maximize the benefits and minimize the side effects of treatment of patients through precision medicine, more efficient and sustainable care. We also heard that the technology that Lars was alluding to also allow us to some extent to achieve that level of efficiency. And I think more related to what Paulo was saying before, really also try to drive the research into the areas aligned with the patients of the interest of the patient. So I think it's sort of paternalistic from the side of certain stakeholders to think that they know what the patient wants. Sometimes we don't ask the patient what they want. We don't then have a good indication of actually where we should actually do our investments for research for the sake of the patient. And so if these are things that we want to do and want to achieve, then I believe that the data flow is actually an important enabler to achieve that. And the problem is right now, there's a lot of hurdles from a technical standpoint that need to be overcome. And the summarizing comment that I would like to make is I think that COVID is actually going to turn our world upside down and actually be a driver for digital innovation and progress on these fronts. Because while right now we have certain absence of systematic measurement of outcomes, we have in some instances an inadequate investment of IT systems, lack of coordination, lack of sharing of data for coordination of care and for research, and a relatively limited appetite for technology for the delivery of care, I think COVID is really pushing us to think how we can actually use technology to address all of that. So I would finish but just by saying that, and then we'll go into the questions that we've been receiving on the chat, just by saying that I truly believe that there's a silver lining to what we're happening with the COVID-19 situation. Is changing a lot of the ways that we are working as humans, as citizens, and as researchers. But I think it will, push us to organically solve some of the problems with the data flow that will boost some of the initiatives that we've heard today. So that's my overlying comment about the three presentations and my own perspective that I wanted to share with you today.
Thank you so much, Federico. And I think it was really rich that we have here more than 1,000 Facebook viewers.